Hello and welcome back. I'm Dr. Gnrh Agonist. Today we are diving into second part of Gnrh Agonist trigger. So let's get started. We'll talk about standard luteal phase support and intensive luteal phase support. Standard luteal phase support. Standard luteal phase support. In this, we'll use progesterone or progesterone plus estradiol, estrogen. Okay, and progesterone at what route? It from which route? From vaginal route or vaginal route. Mainly in our institute, we use 200 milligram TID. Intensive luteal phase. Here we give in intensive luteal phase, we give aggressive supplementation. We give aggressive supplementation of estradiol plus progesterone. So there will be improvement in implantation rate and pregnancy rate. Okay. Then in standard and difference between standard and intensive luteal phase. Okay. Standard is when there is supraphysiological hormonal level are more. So there will be supraphysiological hormone are more. Means because we are giving so much of drugs, gonadotropins and all, so there will be more hormone level, supraphysiological hormone level, which will give a negative effect to hypothalamus and pituitary, ultra loop negative effect to hypothalamus and pituitary. So there will be decrease in endogenous LH. So endogenous LH will be low. Because of this, there will be luteolysis. And what is there in intensive phase? There is because of Gnrh agonist trigger. Example is Gnrh agonist trigger. There will be after the trigger, there will be decrease estradiol and decrease progesterone. Okay. So, to prevent luteal phase dysfunction, we'll give this estradiol and progesterone. So how do we supplement? We have already discussed about the supplementation in the standard luteal phase support. Now we'll discuss about the intensive luteal phase support. We'll give E2 plus progesterone. There we are giving E2 or progesterone, or we can give E2 plus progesterone. Here it's mandatory to give E2 with progesterone, and there will be close monitoring, okay? And there will be in intensive luteal phase support, there will be I have made eyes, close monitoring, and according to that monitoring, we'll adjust the doses. So what we do is, there are two mainly protocol we have seen in intensive. First is Ingman et al. What is his name? Just a second. Ingman et al. And second is Ember et al. Ingman et al. and Ember et al. What Ingman et al. Ingman told to give 50 milligram of progesterone, IM progesterone, and 0.1 milligram of estradiol transdermal. Okay, transdermal. 50 milligram of IM progesterone, this, and 0.1 milligram of estradiol transdermal, 3 patches transdermal, alternative day. Okay, alternative day. And according to this, we'll adjust the dose and we'll give till 10 week. In standard luteal phase support, we were giving till 7 week. Here we'll give till 10 week. Now, what does this Ingman told was? What that Ember told was? Ember et al. They gave 50 milligram IM progesterone in oil with 6 milligram of oral estradiol. How much? 6 milligram of oral estradiol from the day of retrieval. Until 10 week. Okay. Now see, this is Engman et al. This is Ember et al. What does they did? They started with 50 milligram progesterone and estradiol 0.1 milligram transdermal patch every other day, and we'll then adjust the dose according to we'll do serum monitoring and we'll adjust the dose accordingly, and we'll continue until 10-week gestation. In Ember et al., on the retrieval day, we'll start progesterone in oil 50 milligram IM daily and estradiol 6 milligram oral daily until 10 week. Then there was a meta-analysis which showed that clinical in standard luteal phase pregnancy after GnRH agonist, pregnancy rate was 7.9 only. 7.9 only. And with HCG, pregnancy rate was 30.14. 7.9 is very less. Okay, if we give standard luteal phase in GnRH agonist protocol, we'll get a very less pregnancy rate. And in GnRH agonist group, there were pregnancy loss, more pregnancy loss. Okay. In intensive luteal phase support, we saw that Engman et al. In the pregnancy rate were comparable. Pregnancy rate in GnRH agonist and HCG were comparable. Okay. And Imber et al. And Chapio et al. Also showed a significant improvement in pregnancy rate than standard protocol. Okay. Now, the availability of IM progesterone is not universal. What does study show? That IM progesterone. What does study show? IM progesterone, if we use HCG trigger, then it is not superior to other progesterone, not superior. But if we'll give GnRH agonist trigger, it may be essential. It may be essential. IM progesterone. Okay. We'll talk about Engman et al. Study. This Engman et al. They studied in high-risk patient to prevent OHSS. What they give is, they give GnRH agonist trigger in GnRH antagonist protocol. Protocol is GnRH antagonist, and they give GnRH agonist trigger. They give adequate E2 plus progesterone supplementation. There was decreased OHSS, and without implantation rate was similar to HCG trigger. Okay. Reduce the E2 and progesterone supplementation, reduce the rate of OHSS in high-risk patient undergoing IVF without affecting implantation. Now, what they did was, on the start of supplementation, they started supplementation on the day after oocyte retrieval. What did they supplement was, they supplemented progesterone and estradiol. Okay. How did they supplement progesterone? Progesterone was supplemented 50 milligram IM, or it can be added vaginally also. And this 50 milligram IM can also be reached till 75 milligram, increased till 75 milligram. Okay. They can also add micronized vaginal progesterone to make the serum progesterone level, how much it should be? 20 nanogram per ml. Serum progesterone levels should be 20 nanogram per ml. What they did was, they added, again I'm saying, 50 milligram IM. This 50 milligram, they can increase up to 75 milligram. They also sometimes added vaginal micronized progesterone so that progesterone level is above 20 nanogram per ml. Okay. Then they add estradiol. How did they add estradiol? Was they gave 0.1 thrice alternative day. Okay, एक दिन छोड़ के then again, plus minus oral micronized estradiol. How much? 2 milligram to 8 milligram. How much estradiol should be maintained? 200 picogram per ml estradiol should be maintained. How did they monitor the steroid level? They monitored the estradiol and progesterone level at day 3 after oocyte retrieval. On day 3 oocyte retrieval के बाद, on day 3 and on day 7 and weekly thereafter till 10 week. They saw after doing all this, they saw that outcome was 53% ongoing pregnancy rate in the study group and compared to 58.3 in the HCG trigger group. Means it was comparable in both the group, Gnrh agonist and HCG. Gnrh agonist plus luteal phase support and intensive luteal phase support and HCG. Okay. And HCG group. Then here it is shown by the diagram that what they did was they gave Gnrh agonist antagonist protocol. Then they gave Gnrh agonist as a trigger, leuprolide 1 milligram, and then after 36 hours, they did oocyte retrieval. 35 hours, they did oocyte egg retrieval, and 1 day after that, they added progesterone and estradiol, as I have already told you how. And they monitor the estradiol and progesterone level at day 3 of embryo transfer and day 5 of embryo transfer. Day 3 embryo transfer and day 5 embryo transfer. Okay, from the oocyte, day 3 embryo transfer and day 5 embryo transfer. After oocyte retrieval, they at day 3 and day 5 they saw, and then weekly thereafter. After oocyte retrieval, day 3 and day 5 and weekly thereafter. Then discontinue E2 patches and IM progesterone 10-week gestation at 10-week gestation. Now, comparative study on intensive support. Studies have demonstrated that intensive support, including IM progesterone and estradiol supplementation, significantly improve the pregnancy outcome and better than those with the standard HCG trigger support. Ongoing pregnancy rate either comparable, either the after intensive support, either the pregnancy outcome is comparable or better than the HCG. Better than the HCG. Then what is that? Then monitoring and dose adjustment is important. Monitoring and dose adjustment is important. Means personalized approach. There should be a personalized approach. Ongoing pregnancy rate in IVF cycle post-generate with this approach comparative analysis. Okay, effectiveness of intensive support. It is saying that there is a significant improvement ongoing pregnancy rate in the IVF cycle post-Gnrh agonist with this approach. With Gnrh agonist, will give the intensive support. Okay, with dosing and monitoring, same I have told you that we have to maintain a personalized approach to each patient's regimen. Okay, then Adjuvant low dose HCG in fertility treatment. Adjuvant low dose HCG in fertility treatment. What we do is normally LH causes steroidogenesis from CL, corpus luteum. LH support steroidogenesis from the corpus luteum. This is LH work, okay? But when we give GnRH agonist, we need to restore or replace this work. Replace the work of LH, okay? What LH was doing, it was promoting steroidogenesis from the corpus luteum. When we give GnRH agonist, we need to restore or replace the work of LH, plus we need to give steroid exogenously. Okay. So we can give low dose HCG to replace the LH. Okay. But with this, what caution will take is, the caution will take is there can be risk of OHSS. Okay. Now HCG, how, what routes, what, like there can be dual trigger. Either we can give it by dual trigger. Second is at oocyte retrieval. We can give it at oocyte retrieval. Third is 2-day following oocyte retrieval. Or we can give very low HCG 125 from second day of stimulation. These are all the way we can give HCG, either dual trigger at oocyte retrieval, 2 days followed oocyte retrieval, very low dose HCG from second day of the stimulation. Okay. Now we'll first talk about dual trigger. Dual trigger. This give backup for HCG, backup for GnRH agonist failure, backup for GnRH agonist failure. Okay. Failure. Then low, इसमें क्या है? Low dose HCG plus GnRH agonist. GnRH agonist. ये क्या enhance कर रहा है? This enhances luteinization. This enhances luteinization. What is the dose we give in dual trigger is 1000 to 2500 is the dose we give in dual trigger. What all will happen? First is more mature oocyte. More mature oocyte. Second is more embryo. More embryo. Third is we'll have to decrease risk of EFS. Decrease risk of high quality embryo. High quality embryo. We have already discussed this. Fifth is, but we'll have to monitor for OHSS because we have given HCG here. So we'll have to monitor for OHSS. Okay. Your dual trigger. Okay. Up now, there was a study. What all dual trigger, what all it will do? It will enhance luteinization. According to Shapiro et al., HCG doses between 1000 and 2000. Shapiro et al. Said HCG doses between 1000 and 2500 when BMI is less than 33 international unit per kg, there is promising pregnancy rates. Then Griffin et al. Recommended 1000 at international unit HCG plus GnRH agonist, higher pregnancy rate. It said that it causes higher pregnancy rate. Third is backup for GnRH agonist failure, more mature oocyte, better embryos, monitor for OHSS for optimal outcome, balance, benefit and risk ratio. Then adjuvant HCG in IVF at the time of oocyte retrieval. There were, I said, at the time of, I already told you, at the time of oocyte retrieval, 2 days after oocyte retrieval, very low dose. and dual trigger. Dual trigger we have already discussed. Now at the time of oocyte retrieval, there were multiple studies. Humed et al., Karakin et al., and prospective randomized double-blind trial. Okay, what does Humed et al. Humeden et al. Said? Humeden et al. Humeden et al. Said that GnRH agonist plus 1,500 international unit on the day of oocyte retrieval plus standard luteal phase protocol. Delivery rate was similar to traditional HCG trigger. Okay, what it said was when we gave GnRH agonist HCG 1,500 international unit on the day of oocyte retrieval and standard luteal phase support, the delivery rate was equivalent to traditional HCG trigger. Then Karakin et al. Karakin et al. It said that when GnRH agonist was given with HCG, okay, was given with HCG at the oocyte retrieval, VS, we compare it with GnRH agonist trigger plus cryopreserved embryo. So we saw that live birth rate were similar or almost similar. Okay. Live birth rate were almost similar when we give GnRH agonist with HCG at oocyte retrieval or we cryopreserve. This was a fresh cycle and this was a cryopreserve cycle. That means HCG rescues corpus luteum. Okay. That means HCG rescues corpus luteum. That's why pregnancy rate is similar. Then we saw randomized double-blind trial. In that we gave HCG plus GnRH agonist trigger. We with the GnRH agonist trigger VS HCG at oocyte retrieval. Okay. What we saw was we gave HCG with GnRH agonist trigger and HCG at oocyte retrieval. What we saw was there was live birth rate were similar, but higher incidence of OHSS with HCG at oocyte retrieval. This HCG given at oocyte retrieval, there was not significant but slightly higher risk of OHSS when we gave HCG at oocyte retrieval. Then this here we give GnRH agonist, GnRH agonist. Either we give HCG here we did oocyte retrieval. Either we give HCG here. Okay, here we saw that in both similar live birth rate, but slightly higher incidence of OHSS was there when we give HCG with oocyte retrieval. These two places. Okay. Now OHSS risk with adjuvant HCG, slight increase in OHSS incidence. With adjuvant HCG, there is slight risk with OHSS incidence. Okay. Then 2 days now the topic is we gave HCG bolus 2 days after oocyte retrieval. Previously we saw that HCG was given at the day of oocyte retrieval. Now 2 days after oocyte retrieval, there were 2 studies. GnRH agonist, GnRH agonist plus 2 day after we give HCG agonist plus HCG 1,500 international unit 2 day after oocyte retrieval. Okay, oocyte retrieval we gave. Okay, VS versus HCG plus progesterone supplementation. So we saw that HCG trigger. Here GnRH agonist trigger. Here we gave HCG trigger. We saw that plus progesterone supplementation. Similar progesterone and pregnancy. And there was no OHSS. No OHSS in GnRH agonist plus HCG group. HCG which we were giving after 2 days of oocyte retrieval. Another study is Cole et al. We saw we gave GnRH agonist plus HCG 2 days after oocyte retrieval. Same 2 days after oocyte retrieval, we give 1500 HCG. What we saw was there was more E2 level in GnRH. Similar pregnancy rate, higher estradiol level compared to HCG trigger group plus VS HCG trigger. So we saw in this group there was higher estradiol, means this is rescuing corpus luteum. That's why steroid is being secreted, no? The steroid, that's why it's been secreted. Otherwise, if there would be luteolysis, there won't be any steroid. This pregnancy is showing that here similar progesterone level it was shown. Similar means even when we add after 2 days of retrieval, when we are adding HCG, their corpus luteum is getting rescued. In both the study, that it is showing that. This suggests administration of HCG 2 days following oocyte retrieval may rescue the corpus luteum and allow for ongoing steroidogenesis at a sufficient level to support an early pregnancy. Now, very low dose HCG in IVF. Now we come to very low dose HCG in very low dose means how much? 125. Okay. 125 when we'll give we'll start at 2 days or day 2 or day 6 till day 6 of stimulation, and we'll continue it throughout the luteal phase. We'll continue. What is the main benefit? It increases luteal progesterone without external supplementation. We don't have to externally supplement the progesterone. It increases luteal progesterone without the supplementation. We don't have to do external supplementation. It increases the luteal compared to standard luteal phase. Like because we are giving HCG, small doses 125. So that means we have already reached a level of progesterone reaches the level of progesterone which is comparable to standard luteal phase. In luteal phase we are exogenously giving the progesterone, but in this we are not giving the progesterone, we are giving HCG very low dose 125 international unit daily. Now, okay, proof of effective in rescuing corpus luteal function. We need to study it more. Okay. Recombinant LH in luteal phase. Now, recombinant LH will decrease the OHSS risk, and delivery rate will be OHSS risk will decrease, but delivery rate will be comparable delivery rate. Okay, OHSS risk will be decreased, but there will be comparable delivery rate. Now, luteus GnRH agonist will give GnRH agonist in luteal phase. How much GnRH agonist will give? Will begin it at the on the day of embryo transfer will begin, and triptorelin will give this is a GnRH agonist, will give 0.1 mg alternate days. Okay, then it will first day if we are giving in first triptorelin 0.1 mg, second day will give progesterone in oil, third day again will give triptorelin, like that will do alternating with progesterone in oil beginning on the day of embryo transfer. What this will do, it will causes recurrent LH surge to support corpus luteum. Okay. If we'll give GnRH agonist in the luteal phase, what it will do is recurrent LH phase to support corpus luteum. Okay, comparable pregnancy outcome. Pregnancy outcome is good, comparable, and decrease OHSS risk versus we are comparing it with HCG trigger. Now there is one flow chart. Very low dose HCG is 125 international unit. We are starting it on day 2 or 6 of stimulation to luteal phase. It will rescue the corpus luteum. No need of exogenous progesterone. We don't need exogenous progesterone and estradiol. We don't need exogenous progesterone and estradiol. Good clinical pregnancy rate. Further study is needed. Then recombinant LH, luteal phase supplementation, comparable delivery rate are comparable, but no OHS. OHSS नहीं है. ठीक. फिर luteal GnRH agonist, triptorelin 1 milligram every other day, alternating with progesterone in oil, recurrent LH surges, no significant differences pregnancy rate, lower OHSS if we compare it with HCG trigger. Okay. Now, luteal coasting. What is luteal coasting? Luteal coasting, we'll explain with the table. Luteal coasting, in this progesterone is monitored. Okay, progesterone is monitored. If progesterone is dropped, then we'll give 1500 international unit HCG. Okay. What this protocol will do, this will give a luteal supplementation. When we'll see progesterone is low, we'll supplement it with HCG, luteal supplementation, and it will decrease OHSS risk. Luteal supplementation and it will decrease OHSS risk. These two things it will do. Now, Lorenz et al. First study, its series, it showed that progesterone observed luteal progesterone level ranges from 14 to 43.69 nanogram per ml, even if the patient was retrieved with 20 oocytes. If 20 oocytes even retrieved, the level of progesterone was from 14 to 43.69 after GnRH agonist triggering, indicating variable luteolysis. After GnRH agonist, see, there is so much difference, 14 to 43.69. So, there is variable luteolysis. Now, second part of this study showed that if the progesterone level is less than 15 nanogram per ml, if 1500, if with early luteal progesterone level, this is early luteal progesterone level, if we'll give 1500 HCG bolus, pregnancy rate will be good. Means this bolus will rescue the corpus luteum. We'll monitor the progesterone level in luteal coasting. What we'll do is monitor the progesterone level. According to that, we'll supplement HCG. Okay. This is done now. Okay. P4 level rises, can vary 8 folds. Within 90 minutes in a single individual. In the same individual, it can vary 8-fold within 90 minutes. Okay. Now here it is explained with a flow chart. We'll begin luteal coasting. We'll monitor the progesterone level. If progesterone drops significantly, we'll administer HCG bolus. We'll continue monitoring. Proceed with patient care. If not dropped, adequate progesterone level will proceed. If it will drop, we'll give 1,500 international unit HCG bolus. Okay. Then cycle segmentation, cryopreservation of all oocytes and embryo. See, first, Gnrh agonist will cause suboptimal luteal phase. So to overcome, we'll do freezing. Second, when we'll do to prevent OHSS. Third, to allow optimal timing for embryo transfer. When do we need to allow optimal timing for embryo transfer? Like in PGT. Okay. Then fourth, to enhance implantation rate and increase pregnancy rate. To increase implantation rate and to increase pregnancy rate. Now there are studies. First is Manzanares et al. What they did is Manzanares et al. There were PCOS patient with previous cycle cancellation. They freeze all the embryo with subsequent thaw and transfer cycle. Good pregnancy rate were there. Okay. Then Gracio Velasco, high risk OHSS patient they took. They cryopreserved. They saw that 50% in the cryopreserved, if pregnancy rate was 50% in the cryopreserved, then the 29.5% in the patient in which they did coasting and fresh transfer. 50% in the cryopreserve and 29.5% in which they do coasting and fresh transfer. Then Makinjani et al. What they find was they Gnrh agonist trigger and HCG trigger, they freeze all embryos from both the groups. Freeze, thaw, and transfer. What they saw was there was equal implantation rate, clinical pregnancy rate, clinical loss rate, and live birth rate in both the group. So we can say that segmentation causes excellent pregnancy rate, but the issue is with the cost of additional frozen embryo transfer. Then tailoring protocol for highest success rate. Importance of individualized importance of individualized luteal phase management. Predictor of success. What are the predictor of success? Peak E2 level and LH on the day of trigger. Dual trigger strategies enhances live birth rate in specific cases. Now study. Okay. First, what are the predictors? It said there are two predictors. What are they for success? Success, there are two predictors, estradiol level and LH. Estradiol level and LH. Okay. On the day of trigger. On the day of trigger. Now, peak E2 level. Peak E2. If peak E2 is greater than equals to 4,000 and there is raised LH, Gnrh agonist plus intensive luteal phase support, pregnancy is more. Okay. If there is peak E2 and LH, means we don't need to give HCG. If there is peak E2 and LH, only will give Gnrh agonist with luteal phase support. We don't need to give HCG. Why we are not giving HCG? Because we need to prevent OHSS. No, we need to prevent OHSS. So we won't give HCG. We won't give HCG because already peak E2 level are more than 4,000 and LH. So the success of getting pregnant is high. Success of getting. And another, this they are saying that if E2 is 4,000, then pregnancy will be 53.6%. If E2 is less than 4,000, pregnancy is 38.1%. Means when E2 level is low, pregnancy rate is going down. Then Griffin et al. They said that dual trigger GnRH agonist plus HCG, GnRH agonist plus HCG, low dose 1000 international unit. If we with only GnRH agonist, if we compare agonist, if we compare, okay, HCG, if you can, and in both the group, if estradiol level is 4,000, less than 4,000, then the group in which we give HCG with GnRH agonist, pregnancy rate will be high live birth rate. Getting my point? That when the estradiol level is less than 4,000, then giving HCG has worked wonders. Okay. If the estradiol level is less than equals to 4,000, then we are giving HCG. Then there is high live birth rate. Means we'll have to supplement HCG when the estradiol level is less than 4,000. Otherwise, it's enough to have GnRH agonist with intensive luteal phase support. We don't need HCG. Okay. Now, see here also it is told that when GnRH, a predictor of high pregnancy rate is this peak E2 level greater than 4,000 picogram per ml and elevated LH, high clinical pregnancy rate. And Griffin et al. Saw when dual trigger GnRH agonist plus HCG was given, there were high live birth rate if it was estradiol level was less than 4,000, because here HCG was added, no? So live birth rate were increased, because if less than 4,000 mein we'll have to add HCG. Less than 4,000 we'll have to add HCG to increase the live birth rate. Engman et al. It saw that GnRH agonist trigger and 1,000 international unit HCG at trigger and 1,500 at oocyte retrieval, similar live birth rate. Either it was given with the trigger 1,000 or 1,500 at oocyte retrieval. There were similar live birth rate. That is not changing anything. High risk OHSS. GnRH antagonist stimulation protocol. First, we'll monitor serum estradiol level. If it's less than 4,000, what we need to do? We need to add HCG. In what? In GnRH agonist protocol plus intensive luteal phase support. GnRH agonist protocol and intensive luteal phase support, we need to add HCG. And if estradiol level is more than 4,000, we have a OHSS risk. So we won't add HCG. If estradiol level is more than 4,000. Then about follicular monitoring, if less than 25 follicle, less than 25 follicle, greater than 11 millimeter, less than 25, then we'll add HCG in GnRH agonist and intensive luteal phase. If greater than 25 follicle, then we'll freeze all oocyte. We'll give GnRH agonist trigger and we'll freeze all oocyte. Okay, we won't risk anything because we need to prevent this from OHSS. Then conclusion is individualized approach. And the individualized approach is crucial for optimizing conception rate and decreasing OHSS rate. Conception rate in बढ़ाने के लिए and decreasing OHSS rate. Then estradiol and LH tells about the GnRH agonist success rate. Third point is dual trigger. Dual trigger in E2 level is less than 4000. Enhance it. Dual trigger matlab will add HCG. है ना? It will enhance live birth rate. There was one study, na? What study name was? This one. Griffin et al. Griffin et al. Said no that we'll have to add we'll have to give dual trigger if estradiol level is less than 4000 picogram per ml. Okay. Then criteria such as follicular count helps decide between HCG bolus and freeze-all strategies to prevent OHSS. Then OHSS prevention. OHSS prevention. Effective OHSS prevention with GnRH agonist triggered due to short LH surge. Why is it effective? Because GnRH agonist will have short LH surge. Okay, short LH surge, there will be luteolysis and there will be decreased OHSS risk. If OHSS is persisting after giving GnRH agonist trigger, what does that mean? That means either we have given low dose HCG or there is some genetic factor Okay. See, GnRH agonist trigger prevent OHS, inadequate corpus luteum, early corpus luteal demise. Low dose HCG supplementation causes moderate to severe OHSS. If we have given GnRH agonist trigger alone without giving HCG supplementation, if there is reported cases in GnRH trigger alone, if it's given, that means they have some genetic predisposition. Either they will have mutation in GnRH आपका FSH and LH receptor, or they will have variation in gene of VEGF and their receptor. Okay, and any dose of adjuvant HCG high risk for OHSS. Use of GnRH trigger in special clinical situation. Like PGT. PGT will have to do freeze-all. Already discussed. Okay. PGT we have to do freeze-all, and GnRH agonist and HCG in PGT, they'll have euploidy and live birth rate similar. But we know oocyte quality and embryo quality, there is no effect with GnRH. Oocyte donor cycle. Now we'll talk about oocyte donor cycle. Donor and recipient. GnRH agonist versus HCG. There will be similar oocyte retrieved, proportion of matured oocyte, fertilization rate, implantation rate, pregnancy rate, live birth rate in donor, similar. And in recipient, there will be similar pregnancy rate and miscarriage rate. Okay. But the profit in GnRH agonist is, I'm talking about oocyte donation cycle. Okay. There will be decreased OHSS risk in GnRH agonist. Then GnRH agonist trigger in breast cancer. Breast cancer sometimes are estradiol positive, estradiol receptor positive breast cancer. So we all know that GnRH agonist causes luteolysis, so decreased steroids like synthesis, like progesterone and estradiol. Okay, so in if cancer is estradiol positive, we need to have a less estradiol environment. So we can use GnRH agonist, which causes lower serum estradiol level and minimizes OHSS risk. Then safety of GnRH agonist trigger, maternal neonatal outcome and congenital anomaly, similar to HCG. Maternal outcome, neonatal outcome, and congenital anomaly all are similar to HCG. Okay. Then additional benefit of Gnrh agonist trigger. This causes improvement. Gnrh agonist trigger causes improvement in patient comfort and satisfaction. How? It reduces abdominal bloating, pain, ovarian torsion risk because it decreases the size of ovary. ठीक है? Persistent. Okay. Then bloating and there is shorter luteal phase. So periods will shorter how much? 9 days. With Gnrh agonist, luteal phase is for 9 days. So they'll get periods earlier. Then dual trigger study for improved outcome. First is combination of we know what is dual trigger will given if there is a history of immature oocyte, if there is a history of empty follicular syndrome, or if there is history of low fertilization risk, low fertilization, then we'll give dual trigger. And it has an advantage of having natural LH and FSH surge, natural like, okay, LH and FSH surge. Then towards safer and more effective art practices. In this, now we focus on singleton, healthy singleton. Now we are focusing on healthy singleton live birth rate and without OHSS. So now it is proposed to modify reporting system to include OHSS rate and encourage practice to avoid OHSS. This is particularly important for high responder like PCOS, those undergoing elective cryopreservation and oocyte donor where safety is paramount. Okay. Okay. Thank you.